Hi, welcome to my channel. I am Dr. Rajiv Harshe. Today's topic is fluoroscopy in interventional pain management. We all know that in interventional pain management, we do fluoroscopy guided procedures or ultrasound guided procedures or blind procedures. So today we'll be trying to understand how we use fluoroscope and the details of it. The objectives are understand the principles of fluoroscopy and applications, learn about different types of fluoroscopes and their mechanisms, explore fluoroscopic techniques for managing pain in spine pain, knee, shoulder, and cranium originated pains, discuss advanced technologies like O-arm and cath lab fluoroscopy, review safety considerations and limitations. Fluoroscopy is real-time X-ray imaging technology used to guide interventional procedures. It enables the precision in needle placement, improves the patient outcomes by minimizing risks, and provides dynamic visualization of the anatomic structures. What are the type of fluoroscopes? The most common we use is C-arm. Why it is called C-arm? Because it is shaped like C, right? And this is its control. From here, the X-rays come, this receives, and then it is processed here. It is portable, commonly used, and provides real-time 2D imaging. There are some flat panel fluoroscope where the receiver is flat. Okay, it gives high resolution, distortion-free imaging, is compact and lightweight design. Then comes the digital fluoroscope where the image processing is digital. So the clarity of the image is much better. Then there are O-arm fluoroscopes. These are on the horizon. People have started using it, but the cost is prohibitive, and that is why it is not seen everywhere. But yes, this is extremely good because you can see 2D and 3D imaging. Imagine you're doing vertebroplasty and you take say oblique view. You put the needle, then you go lateral, again come oblique, AP, oblique. Here you can get all the pictures in one go. So you can see three images, so you can easily and quickly do the procedures and with precision. It's more commonly used for spine interventions. Then there is something called cath lab fluoroscope, which everybody has in the hospital, but this is not much used by pain consultants because of non-availability. But believe me, this is way better than our routine CM. Reason is this whole table is radiolucent. A. Second, the movements are motorized, so pretty precise. And third, the imaging quality is extremely good. What is the working mechanism? Well, it has two components, X-ray source and detector and image intensifier or flat panel detector. X-rays pass to the patient, creating an image on the detector. The real-time images are displayed on the monitor for guidance. What are the key technologies used? Digital image enhancement. This is used in digital fluoroscopes. And low-dose radiation technique. This is also seen in advanced machines. Now we need to understand what is kV and MA, which are the commonly used terminology when we use fluoroscope, and the controls are there on the control panel. kV is kilowatt and MA is milliampere. Now, what is it and how does it matter? kV represents the potential difference across X-ray tube, determines the energy, that is the penetrating power of the X-rays. Higher the kV, greater the penetration, but lower the image contrast. In milliampere, this indicates current passing through the X-ray tube, determines the number of X-rays or photons produced. Higher the MA increases image brightness, but there is a higher patient dose. So MA should not be much increased because it will increase the higher patient dose. You can increase the kV to improve the penetration power and have better image. So remember, don't increase the MA much. You can increase the kV for lateral views. MA controls the tube current, which is directly related to quantity of X-rays produced. Higher MA causes higher number of X-rays and high radiation dose. In fluoroscopy, the image is usually kept low to minimize radiation as it operates continuously. kV controls the energy or penetrating power of the X-rays. Higher the kV produces X-rays with greater energy that can penetrate deeper tissues. While increasing kV can increase the dose to some extent, it generally affects image quality and contrast more than the radiation dose. Higher kV leads to lower contrast, that is less differentiation between soft tissues, but slightly reduces radiation dose for the same image because X-rays are more efficiently transmitted through the body. kV is adjusted to optimize tissue penetration and contrast. MA is modulated to balance image quality and minimize radiation exposure. KV and MA work together hand in hand to ensure diagnostic image clarity. Well, application of fluoroscopy in anteroposterior view. The KV setting generally is moderate 70 to 90 kV to penetrate medium thickness. MA is adjusted based on patient size, typically low for reduced radiation. AP view generally involves area of uniform thickness. In oblique view, there is slightly increased kV, like 80 to 100 kV, due to angle penetration. MA requires increase to maintain image brightness, and because oblique view often encounters varying tissue densities. In lateral view, the kV has to be 90 to 110 kV to penetrate thicker anatomical areas. Of course, these things vary according to thickness of the patient. These are Western figures. In Indian context, naturally, we will have to reduce and see the image quality. In MS setting, higher MA to compensate for scatter and maintain quality is also done in lateral view in some patients. Lateral views involves greater tissue thickness and beam scattering. That is why these changes are needed. So in lateral view, first increase the kV. If you can get a good quality, don't touch MA. Why adjust kV and MA for each view? Beam penetration. Different views require varying levels of penetration for clarity. Image contrast. Maintaining optimal contrast for diagnostic accuracy. And radiation safety. Balancing the image quality with the minimum patient exposure. Both things are important, right? Image quality as well as the exposure to the radiation. Now coming to the fluoroscope operating panel. The key controls are fluoroscopy mode, X-ray setting, and image storage. The fluoroscopy mode adjusts real-time imaging. X-ray settings are there to control radiation dose and intensity. And image storage controls are, it captures still images or video sequences. The advanced features include image zoom and contrast adjustment, rational controls for O-arm systems. O-arm is something so new that we hardly know much about it, but this is going to be the future. Safety considerations. Radiation protection. Always use various radiation protection tools which we have already covered in radiation protection lecture. But to brief, you can use lead aprons, lead shields, lead goggles, lead gloves. Minimize fluoroscope time to reduce the exposure. For patient safety, pre-procedure planning to avoid critical structures. So anatomical planning before actually shooting the X-ray is much important, and the machine has to be regularly calibrated so that we know exactly how much radiation is going. What are the challenges and limitations? Higher cost of advanced fluoroscopy system. These are costly instruments, especially the digital and the flat panels. O, of course, is very high. Then it is not available in all centers, and there are a lot of factors which operator can decide to give the outcome. So the training of the operator matters a lot. What are the imaging views in fluoroscopy? We take cranial quadrant views. This is angle projection for spine visualization. Oblique views generally done for foraminal and joint clarity in spine. Lateral views for depth perception and structural profiles. What is importance of word parallax? Everywhere you will listen, remove the parallax, right? So The issues are misalignment in 2D imaging leading to errors in trajectory interpretation, meaning you plan to put a needle somewhere and the needle goes somewhere if the parallax is not removed. How do you see that? Like making the two lines parallel. For example, take a vertebra, take its upper border and lower margin, upper margin. It should be parallel if you are trying to work in that area. Suppose disc, then the lower margin of upper vertebra and upper margin of the lower vertebra should be parallel. Then that disc you can work better. Likewise, OAM and cath lab fluoroscopy provide true 3D imaging, minimizing the parallax, and this is inbuilt in that. So that way also cath lab is way better. OAM fluoroscope. Let's have a brief overview of what is this new thing. It combines fluoroscopy and CT-like 3D imaging. Its real-time navigation and comprehensive anatomical visualization really helps. It is used in vertebroplasty, kyphoplasty, and pedicle screw placement. It reduces risk of cement leakage and adjacent tissue damage. Well, in vertebroplasty, 3D imaging ensures accurate cement placement. Its real-time update reduces potential risks, like the cement doesn't go anywhere else but at the desired site. And it combines pre, intra, and post-operative imaging, right? Comparing cath lab and CM. In cath lab, the resolution is higher and advanced processing features are there. So this is way better than the conventional CM. CM is portable and cost effective. It has limited resolution for complex interventions. In spine, the applications are epidural steroid injection, facet injections, medial branch block, vertebroplasty, kyphoplasty, disc procedures, so on and so forth. The techniques include cranial tilt, caudal tilt, oblique and lateral views for optimal needle guidance. This will cover in individual interventions. The benefits are precise targeting and reduced risk of nerve injury or tissue damage. In knee joint, it is used for genicular nerve blocks or intra-articular injections. Lateral and oblique views are used for optimal visualization. The benefits are accurate drug delivery, improved patient outcome because you have delivered the drug perfectly where it has to go. In obese patients especially, this is very useful. In shoulder joint, suprascapular nerve block, hydrodilatation, intra-articular injections are the commonly used techniques, interventions where we use fluoroscopy. It enhances precision uh, in targeting the joint capsule and reduces potential risks and improves the outcomes. In case of cranial pain management, trigeminal RFTC, trigeminal block, occipital block, sphenopalatine ganglion block, these are all commonly done procedures under fluoroscopy, and this requires accurate needle alignment to avoid critical structures. So fluoroscopy helps. And advanced imaging views like oblique and lateral, they improve the accuracy. Concluding, what we can say is fluoroscopy, especially with OARM and cath lab system, revolutionizes the pain management. These advanced technologies ensure precision, safety, and better outcomes. Investment in training and equipment is crucial for widespread benefits. Thank you very much. This concludes my topic, fluoroscopy in pain management. If you have liked this video, please share it with your friends and those who wish to learn pain management. Also, please subscribe my channel and click the bell icon so that you will get notifications of my future videos. Thank you very much.